And on the right, you all recognize him? Michael Douglas. There was a laugh in the audience because oropharyngeal cancer also can be HPV related. Okay? And we're not going to explore how he may have contracted HPV. But it just shows you that the stigma is lost, okay? No longer is that stigma there. You can only have one sexual partner and you can be exposed to HPV, okay? Dealing with the other aspect, early detection and risk reduction. Well, we heard Omar speak about his dad being old-fashioned and didn't go to a doctor. Is it old-fashioned? Nobody likes a doctor the same way nobody likes a dentist, right? When they go there, they know it involves some level of discomfort. And it's not easy to undergo these tests. You can see a mammogram being performed, top left-hand corner. It's uncomfortable. Bottom right-hand corner, colonoscopy, that looks at your intestines for precancerous lesions like polyps. And on the right, the digital rectal examination as part of your prostate cancer screening. We don't go out. We don't want it. Why? But then if we're encouraged by our peers, you know, if it's mandatory, you have insurance, and you say, listen, I'm going to get a wellness certificate, you get these tests done, and you can pick up cancer in the early stages. And there are societies in Barbados who are advocating screening tests. The Barbados Cancer Society, the Barbados Family Planning Association, and the Cancer Support Services. So the Cancer Society has their own breast screening program, where they offer mammography screening. They do pap smears there too as well. The Barbados Family Planning Association is one of the first NGOs to offer the HPV vaccine in Barbados. And they subsidize the cost through fundraising events and cancer support services. They do PSAs, prostatic-specific antigen testing. So they go out there and they recruit men from different organizations, the Sanitation Authority, to get their PSAs done. And this is Dr. George Nicholas Papanikolaou, born in Greece in 1883, and he was the gentleman, not me, responsible for realizing the examination of cells and vaginal discharge can reveal precancerous lesions. So ladies, when you go for your pap smear, he's the one to blame, okay? Not your gynecologist. He's the one that found the precancerous lesions when he was looking at vaginal secretions and found that you can predict changes in the cervix that can lead to cancer. And simple thing to remind those who haven't had their pap smear, this is how it's done. Basically, a speculum is inserted, a spatula is used to remove the cells that are coming off the cervix, and those are put on a slide and sent to be analyzed by a lab. Okay? And here we have a cytologist. So just imagine the process involved. You have to visit a doctor or nurse. You have to get up into an uncomfortable position, expose yourself, have a speculum, cold speculum most of the time. It doesn't have to be cold. We just use it because it's sterilized and it's metal. You have to get them remove cells from the cervix, put it on a slide. Somebody has to carry that slide to a laboratory. A cytologist has to look at that slide now, analyze the cells, write a report. That report has to be transcribed and typed by a typist, goes back to the cytologist, signed and approved, and then that result is couriered back to the doctor and nurse practitioner. Okay? There are 2 cytologists at the QEH in Barbados, and probably 6 on the island. The population of Barbados is 260,000. I think more than 50% are women, so we divide that by 2, and how many of them should be getting pap smears? That's just giving you numbers, okay? So when one of the cytologists, Miss Celia, goes on holiday, all those slides that are on her desk remain there until she comes back, because the other person not doing more than she's supposed to do. Why I mentioned Celia, because she was actually sponsored by BACA to go overseas and get her cytological training. So it just shows you the impact a society like BACA can have on a country. You have 2 cytologists in Barbados. One has been helped by BACA. It shows it, right? And then, if these cells are abnormal, the client is called back, and they're referred to something called colposcopy, the colposcopy clinic. And did you know that colposcope I've been using for the last 7 years was also donated to the hospital by BACA? And I only found that out last night at dinner with Dr. Paris. So you can see the effect that an organization like this is having on the healthcare of a country. And then when it comes to quality cancer care, I think what's important is the timeliness and the patient-centered approach. And we heard Diana mention, because of a co-payment of $20, they tried to call her, couldn't get through, and that was left aside. She was just a name, a number in the pharmacy. She wasn't a person to that person. And Omar mentioned you have to be passionate about cancer care to make a difference. And you do. Because if you realize that Diana was somebody's mother, a 23-year-old's mother, somebody's wife, somebody's friend, you think they would have left it at that? She needed this medication. And that's where the patient-centered approach is very important. Now, we're fortunate in Barbados that healthcare is free. When I worked in Jamaica at the University Hospital of the West Indies, it took over 3 months to get back a PAP result. 3 months. But now it's free. Guess how long it takes? 2 years. Because you have more people accessing healthcare in Jamaica, that has put a burden on the cytologist there. So by the time your next pap smear is due, you still haven't gotten the result for the first one that you did. And the Pan American Health Organization is trying to implement strategies, maybe move away from doing pap smears because they realize it's a burden on their resources, to something more crude, which is practiced in Southeast Asia and parts of Africa, where you just look at the cervix, you apply some vinegar, and if you see abnormal cells, you treat it at the same time. Now, we think of it as being good, you know, or visual inspection with acetic acid. It's easy to do, everyone can do it, but then you overtreat. And treatment is not without side effects. And then I went to do my fellowship at Tata Memorial Hospital in Mumbai, where I did a biopsy at 11 a.m., went for lunch, and when I returned at 1 p.m., I didn't have a 2-hour lunch, by the way. I could look at the computer system, and the result was available. Now, that's what we should be aiming for. Because imagine, just the same way they've made an HIV test mandatory that you get back a result within 24 hours, because there is anxiety. The main reason you're coming to do that test means that you have some concern. You go home, you don't sleep, you come back the next day, and you get the result. You feel good. You do a pap smear now, you have to wait 6 weeks. That's how long it takes in Barbados. Now, yes, you can get it done quicker. You may have a friend who works in the lab. Barbados is small. You call a friend that calls somebody else, and you know within 2 or 3 days, man, you got that result. But why does it mean that you have to call somebody to get a result? Why can't everybody be friends? All right, the same way that one person gets it back. And that's where the Healthy Caribbean Coalition came in. Their organization, formed from the heads of states of all the Caribbean islands, basically to try and reduce the burden of non-communicable diseases in the region. And we met in St. Martin. And these are representatives from all the cancer societies in the region. From Jamaica, she's there in red. I'm from Barbados Cancer Society. There's people there from all over. And one of the things that they came about, they shared resources. You know, you do something and you have challenges doing it, trying to raise money, and you realize, boy, this is a problem, I have to do it a different way. All these cancer societies are doing the same thing independently. And they can't share each other's experience because you know there are going to be certain challenges or roadblocks when you try to do something. And if you take somebody's mistake, you don't make that mistake. And they're never integrated before. And that's what the Healthy Caribbean Coalition did. They brought these people together so that they can share ideas. People had the same ideas. Some of them had novel ideas. And they came together. And one of the main things out of that meeting was that, listen, we needed to increase women's access to affordable cervical cancer screening. What that meant? Well, when you go to a clinic, there's privacy. Whether it meant there was a gown available for that woman to cover herself with, because that was one of the challenges. A woman would not go for it because there was no gown. So she had to strip, lie down in a bed, the AC is on, she's cold, the curtain flapping, anybody that passes outside gets a peek. She's not going for that pap smear. And something as simple as that prevented a woman from having her pap smear done. You believe that? Just a gown being present. And if you don't realize the simple logistical issues, as a woman, it's a very intimate and personal experience. And they came about with this e-petition to increase women's access to affordable cervical cancer screening. And we know the burden of diseases is large. So they've approached heads of governments through an e-petition, which all of you can sign, www.endcervicalcancernow.org, which basically is trying to get 500,000 persons in the region come together and tell governments, listen, this is something we want for our women. Because cervical cancer screening, the pap test, is actually one of the most successful screening tests ever found. And it has reduced the incidence of cervical cancer by 70%, only where it has been effectively implemented. But yet, cervical cancer remains a leading cause of death in countries without effective screening programs. So the areas in red highlight the areas where cervical cancer is still prominent. So where I did my fellowship, here, there in India, look at Africa, look at South America, and look at the Caribbean. Now when I first started this, I said, what do they all share in common? All of them are south of the equator. So it probably has to do with the southern hemisphere. That's my thinking, right? It makes sense. Why would the northern countries not have a high prevalence? But then I zoomed in on the Caribbean. And we see Jamaica there, dread in red. We see Cuba. And look, nestled among the islands, you can see Barbados, that tiny little dot, still orange, still shining. But look up Florida and Puerto Rico. They're in the southern hemisphere, but they're in a nice pastel yellow. Their incidence is not that high. So what's it due to? It's not the American passport or the green card that's preventing them from getting cervical cancer. It has to do with poor policy, poor access to screening and treatment services, because in America it's also prominent. You have to have health insurance, right, to be able to survive. Only with Obamacare or Medicare now is it making those persons who don't have insurance be able to access health care. And because of poor access to screening and treatment services in the Caribbean, the vast majority of deaths occur in women living in low and middle income countries. So it costs more to be poor. And that's actually poor economics, because it costs more. By being poor, you get higher rates of cervical cancer, and a lot of your healthcare budget now is going towards treating those patients when prevention is better than cure. And then you may wonder how clinical trials can impact access to healthcare. How can that be a barrier? Well, unless we have organizations like the Chronic Disease Research Center or the Barbados National Registry, we won't know which cancers are affecting our population to therefore then allocate adequate number of resources to these things. And what I mean by that is that look at the incidence in blue and look at the mortality in red. Now everybody knows about breast cancer. There are many walks for breast cancer. There are many outreach programs because you see how common it is? Look in blue. A lot of people, women, have breast cancer, get breast cancer. Look at the mortality in red. But women survive because they have screening tests. The breasts are easily accessible. Although it's a personal experience to get breast cancer screening or mammography done, it's still not like cervical cancer where it's a little bit more invasive. And if you look at the mortality in red with cervical cancer, it's nearly 40%. If you look at breast cancer, when I say percent-wise, right? Look at the line in blue for breast cancer and look at the line in red underneath. That's about less than 20%, okay? Look at cervical cancer. Nearly half of the ones in blue, you have that in red. Look at ovarian cancer, the last one on the list with the arrow next to it. More than 50-60% mortality. And when you add up the mortality of these gynecological below-the-belt cancers, is actually higher than breast. So more women are dying because of gynecological cancers. And that's how research helps us, because if we didn't know what the main cancers that are in Barbados, the main ones causing death, then we don't know how to allocate our resources. And another way how research helps is looking at causative factors. Now we know cervical cancer is caused by HPV. The vaccine, you all may be familiar with Gardasil, the other vaccine is Cervarix, contains 4 HPV serotypes. 6 and 11, which are the HPV viruses that cause warts, and 16 and 18, the ones that cause the high-risk viruses that cause cervical cancer. But research out of Jamaica and Barbados show that in the Caribbean, it's HPV 45. So although we're implementing the vaccine, the one that's called, now there is cross coverage between the serotypes. But if we didn't know that, and we invest in this policy where we give the vaccine free and we don't see the changes that we're expecting to see, the other countries are seeing, we can probably explain why. Okay? So we need to do our own research to plan cancer care. And that's where the integration of evidence-based practice to continuously improve care is important. And this is again going back to the Institute of Medicine's guideline. And I think this is also an important projection. This is a WHO projection. If you look at cancer, the top line in black, coming from 2004 to 2030, is actually leading the charge. Why are more people getting cancer? Because more people are living longer. The more people are living longer, more chance of them getting cancer. And yes, you see ischemic heart disease and stroke are very important too as well. And those are also non-communicable diseases. But cancer is the number one non-communicable disease out there. Okay? And then, treatment. Well, treatment is tertiary prevention, which is a treatment of invasive cancer. So at any age, ablative surgery, radiotherapy, chemotherapy, we're talking about treatment. I'm a gynae oncologist. So doing gynecological oncology surgery, doing colposcopy, doing radical surgery is important. I'm not sure if everybody saw that, but those who are a little bit squirmish may want to close your eyes, because I'm going to show you cancer in a private part, which looks very gross. So, and radical surgery that was done. Her whole vulva and groin nodes were removed. And her after. And why I showed you that? Because I returned to Barbados October 15th. And I found that patient. When I find that patient, I'll explain to you. Her granddaughter works on the labor ward. She came to me and said, Dr. Chatrani, can you write me a prescription for xylocaine jelly? I tried to get it outside, but I couldn't get it at the private pharmacy. It's only available at the hospital. So can you write it on a hospital prescription pad? Now, those who don't know, xylocaine jelly is a numbing gel. Why would a young girl come to me and ask me for a numbing gel? So my mind started to wonder. So I said, Anne-Marie, why do you want a numbing gel? It's for you, for your boyfriend? No. It's for my nana. I said, explain to me. Well, she went to her doctor and she has a growth down there that's biting her, itching her, burning her. And he prescribed this jelly to put on it. Her grandmother was 95 years old. I said was, okay? She came to, that was Thursday, she came to our clinic on Monday. I told her, let her come. She was actually in the book for surgery, huh? From since March, this is November. They were waiting for somebody to come back to do the surgery. And then being 95, people were saying, she's lived her life. You know, why trouble her? When she walked into that clinic and you saw her spirit, we were thinking maybe we can do a palliative procedure, just remove the tumor, nothing major. But when she walked in there, no hypertension, no diabetes, no problems. We said, man, if we have to put her to sleep or give her anesthesia, might as well try. And I got flack for it, because when she went to the high dependency unit, she spent 2 weeks there recovering, getting dressings. People were like, wait, let a little old lady die in peace. Right? She went home January 31st. She celebrated her 96th birthday. She called me and told me, man, I had a Heineken, man, that drunk me. And I tell her, man, you're a cheap date, man, one drink and you're gone. And this is October. This is September. 11 months since her surgery. She didn't need any, she had stage 3 cancer, huh? She didn't need any adjuvant chemo or radiation. And she's walking around well. And I have a picture of her that I'm going to show you today. Now, we all thought in our back of our mind, let's leave her alone. She wouldn't have been able to survive with a good quality of life without that care. And since then, I've gone back. We started a tumor board, which is in keeping with a multidisciplinary team in the approach to cancer care. And it took me 5 months to get that tumor board running. Letters back and forth, trying to get everybody's schedule together for them to come together. And we got the radiologists, the pathologists, the oncologists, the gynae surgeon, and the hematologist to come together and meet. If I'm not there, that doesn't happen, that meeting. So when making my plans, we have it the second Wednesday of every month. I had to leave Thursday to come for this conference. Because if I wasn't there, it would fall by the wayside. And a system like this cannot depend on one individual. It has to be a system that if somebody's not there, care still continues. I've sent in a proposal to the hospital, the ministry, for a gynae oncology service, because imagine you have 6 women booked for fibroid surgery, right? Benign surgery. And then somebody comes to you with cancer. What do? You don't have any bookings for the next 3 months. Do you wait 3 months and then book her? No. So you book her for surgery. One of the persons who has fibroids, who's supposed to get surgery, who took leave from work, who asked their sister to come from overseas for the 2 or 3 weeks to help them for the recovery process, gets cancelled. So you're disrupting somebody's life. But you're putting a priority to the cancer while disrupting somebody else. And you can't have benign and oncological cases competing for the same space. Because at the end of the day, the benign will lose. So I've asked for operative time, dedicated OT time, and some place like Jamaica with limited resources, they have a dedicated gynae oncology list. Okay? Simple things. And I asked the CEO, I asked the Director of Medical Services, their answer, where's the money going to come from? So I went back, we didn't accept that as defeat. We went to the drawing board and we were like, well, where's the money going to come from? Healthcare is free in Barbados. You can't charge people. So that's when we put on our thinking caps and we actually started to let our colleagues know in the region, in the neighboring islands, that gynae oncology services are being offered in Barbados. And since then, which is about 4 months, we've had 3 referrals from as far as Turks and Caicos, Antigua, and St. Vincent. And they come, they get their surgery, they get their care, they have chemo in their countries, and they go back for the chemo. So no longer do they have to go to the United States, where the care is going to be exuberant. Obviously, we're going to see if we can accept it, if the resources that we have are able to do it. If not, we'll advise them, no, we're not just doing it as a money-making venture, but we're doing it to improve our services while helping other people. And then one of my colleagues approached me. And he was contacted by an international organization called Globathon to captain the Globathon team in Barbados. Now, I'm a runner. When I saw Globathon, I was like, this sounds like a race, a marathon or something. But this is actually a walk to end women's cancer, which started right here in America. Started 2 years ago with a 72-hour relay, and then a 24-hour the year after around the White House to promote awareness for women's cancers. Now, when you say women's cancers, they actually focus on below-the-belt women's cancers, because there are many walks for breast cancer. But this personal area gets neglected. And they asked me just to be the team leader and represent Barbados in over 80 countries in having a walk and hosting a walk. They said it didn't have to be a money-making venture. It didn't require too much. And it's happening all over the world on the 29th of September, in New Mexico, Hong Kong, Egypt, Georgia. So I said, fine, we'll do it. We'll represent, because it will increase awareness. But then I said, let's make this something that can benefit also from a financial point of view, the women's cancer services at the QEH. And that's my 96-year-old on the left. She's representing Globathon too as well. So we have a public service announcement where she's speaking. This is her standing outside the Barbados Cancer Society. This is me and Dr. Dorothy Cook-Johnson. We didn't actually go down to Parliament Building. That's the beauty of Photoshop, okay? Take a picture and then put the picture behind. And we've gotten the likes of Alison Hines, Carolyn Boyce, the Minister of Health's wife, and a radio personality, Gaynell Marshall, to come together to lead a team of walkers. And why 3 individuals? Because we're going to have Alison representing awareness. She talks openly about her cervical pap smear, when she had her test, what her results show. Because we want to encourage people no longer to brush that one under the rug. Come out there and speak about it. Get other people involved. We got Carolyn Boyce for 2 reasons. The Minister of Health's wife, 1, plus she's an educator. So she's going to be leading the education and research arm. And then Gaynell Marshall's on the radio. That's free publicity for us. Every time she speaks on the radio, she's going to talk, I'm there. Come out, okay? And we got this under the auspices of the Barbados Cancer Society. and multiple corporate sponsors from corporate Barbados. The First Citizens Bank is now the title sponsor in the Walk to End Women's Cancer, Globathon Barbados. And we've shown that one step, or we will show that one step can make a difference. And the proceeds are in aid of improving women cancer services at the QEH. The QEH came on board. It took me a lot of communication. I sent emails, got no response, met with the minister. And this is an organization looking to give money to the hospital. And it was hard to get a response. And you wonder why. Somebody don't check the email. Or they don't reply emails. They read it, they have to print it out, and then they write something. It depends on somebody else to reply it. Then the minister changes. Then you have elections. Then you have the budget. So unless you follow that up with a phone call or a meeting, you don't get a response. And Dr. Paris told me he's had the same challenges. And these are our champions: Carolyn Boyce, Alison Hines, and Gaynell Marshall. And look at the outpour from corporate Barbados. Gold sponsors, silver sponsors, bronze sponsors. Organizations like BART, the Barbados Association of Retired Persons, they have a 35,000 strong membership. That's a lot. They're building a $6 million facility in St. Philip. You wonder where they get that money from? But just dues. If you got 35,000 members and you got $100 a head, do the math. That's 3.5 million, right? And we know there are challenges. Being vice president of BAMP, QEH budget has just been cut by $35 million. And this is what you see in the newspaper. QEH already struggling. When I say already struggling, I have cancer patients who can't get chemotherapy because $2.1 million is owed to Collins, who brings in the chemotherapy drugs to Barbados. The hospital hasn't paid their bill, so they're not giving them any more. So patients come back after. I expect them to be having chemo. I have everybody in my database, and I call them just to check and see how they're doing. Oh, I haven't gotten the chemo. They said they will call me. And the same way you know they will call me, if somebody doesn't call you, they sit by their phone and they wait for that call, you know. But they haven't been called. So unless I call to find out what's going on, oh, they said they don't have the drugs. You call, you have to find out, it costs $30. They said, can you get the $30 and somebody buy the drug and bring it to your hospital? You call back the oncology department. They said, yes, if they bring the drug, we'll give it. And we're not going to compromise the standard of care. That's what is said in the media. But the care is being compromised. If already they're juggling with a low economic budget and having to give proper care. And we have benefited from philanthropy. The Maria Holder Memorial Fund, that's actually built the Diabetic Association Center in Warrens. From BACA, you see just 2 projects that they've contributed to in my department. In the middle, you have Angela Simpson. She's a breast cancer survivor. She is the wife of John B. Simpson, those who are familiar with JB Supermarket. And she's a patron of the Barbados Cancer Society. And do you all recognize that lady on the right? That's Rihanna, ambassador to Barbados, and probably the most famous natural resource Barbados has now. No longer is it sugar or tourism. It's Rihanna. And she's actually donated 3.5 million Barbados dollars, US 1.75 million, in honor of her late grandmother. So the oncology department was renamed the Clara Brathwaite Center for Oncology and Nuclear Medicine. And with that money, they actually bought the Equinox external beam cobalt system, valued at 638,000 US dollars. It was purchased and installed and went live around June this year. Other 2 pieces of equipment are coming: a brachytherapy planning system, another 600,000, and a gamma camera, 350,000, will be delivered in March 2014. Philanthropy, organization like yours that is making healthcare survive in Barbados. And then, not to neglect the cycle of social care and survivorship. You have cancer survivors. But cancer doesn't affect one individual, it affects a family. And support, and this area was actually neglected for a long time. And Cancer Support Services is one of the organizations in Barbados leading the charge. They're providing support, whether it be financial, whether it be emotional. And these are all important aspects of cancer care. Because if you don't know how to deal with Some people think of it as a death sentence. And we have a live example here today, somebody who's been diagnosed with 3 separate cancers and is alive and well and a productive member of society. It's not a death sentence. It's a non-communicable disease that there is treatment modalities for. Okay? And you have those with terminal cancer who need palliative care. And this organization, the Barbados Association of Palliative Care, has only been formed about 2 or 3 years ago. And there's a drive from BACA, I'm not sure if the members know, but to get a hospice in Barbados offering palliative care services. Now, people neglect it because they end up saying, well, that person on their way out, why waste money going towards that? But that's important because that person is a person, right? That's an individual. That could be you or me. The pain and the suffering. Unless you address it, there's no way you can improve cancer care. So it requires us to change our mindsets, change our attitude and behavior towards cancer for it to improve. And we have to get the policymakers on board. Thank you.
What a terrific presentation. Yeah, there'll be time for questions later after the next presentation. Clearly, Dr. Chatrani is one of the rising stars in the university system there, hospital in Barbados, and we look forward to supporting him and the efforts that he's making or trying to make to improve cancer care and to help reduce barriers to cancer care in Barbados. Thanks again. Yeah. Yeah. Next speaker is Dr. Camille Reagan, and she hails from Jamaica. So from Barbados to Jamaica. She's based here, though, in the United States. And she's a graduate of the University of Pittsburgh Graduate School of Public Health with a PhD in infectious diseases and microbiology. And she did her postdoc there as well and has an MPH in epidemiology. And her current substantive post is at the Fox Chase Cancer Center, and you'll tell us a little bit about that when you speak. And her research is focused on cancer epidemiology and cancer prevention in minority populations. And in 2006, she established the African Caribbean Cancer Consortium, a research group designed to promote collaboration between cancer researchers who focus their work in populations of African ancestry. Welcome, Dr. Reagan.
One of the NCI, the National Cancer Institute's designated cancer centers, one of 41 cancer centers in the United States, and we're based in Philadelphia, so not too far from New York. The work that I focus on, of course, is epidemiology, and that is a very broad discipline because it involves population-based research where we look at environmental factors and genetic factors and other lifestyle-related factors to see how all of that ties in with the development of cancer. I do have a laboratory, so I do a lot of laboratory work as well, but today I'm not going to present anything from the lab. I had a little bit of thought as to how to focus this talk because we wanted to be able to focus on barriers to cancer care. And so what I will present today will be just snippets of some of the research that I've done that will sort of address or bring the discussion towards those type of barriers. And I must say too that the focus that I have is more prevention. So more looking at the preventative care aspects and some of the barriers related to prevention. And then also I will touch on some of the topics related to treatment and survivorship. Okay, so this is just to bring everything in perspective. We all know that cancer is a terrible disease, and as an epidemiologist, we always like to show statistics. So these are the cancer rates or the incidence rates in the United States, and I have it separated according to race. The black individuals are in blue, and the white individuals are in red. And as you can see, the blue line is above the red line. So that tells you that the rates or the incidence, the number of new cases that are diagnosed each year is actually higher in black individuals compared to whites. What you do see, though, is that there seems to be a downturn. So the very last, oh dear, the very last point is in 2010. And you see that both of the rates are very close together. This is actually attributed possibly to the smoking-related cancers that we have. Lung cancer is on the decline. Part of that has a lot to do with smoking cessation and all of the research that surrounds tobacco exposure and all of the programs that have been implemented to try to raise awareness about tobacco use and smoking. And so if you were to look at the individual cancers, these are all cancers combined. If you were to look at individual cancers, you'll actually see that lung cancer is on the decline, both for black and white individuals, but the rates are still higher for black compared to whites. Now, on the other hand, if you look at survival, there's a difference. So despite the fact that the incidence seems to be getting a little bit closer by race, you still see that survival is poor. So this is the percent survival. So it means that a black individual has a much, after over 10 years, their likelihood of survival is close to 50%. That's the last point. Can't seem to get this last point here. Survival rate is about 50% after 10 years of diagnosis from cancer, while a white individual is much higher. It's a little bit above 60%. So that's one of the major problems that we have in the United States. This is what we talk about when we address disparities related to cancer. And those are some of the things that I have focused my research on. So with respect to cancer care, this is a very busy slide, but I'm just going to highlight a few points. The cancer care continuum is something that we've talked about a lot in the United States, and it just really gives you an overview of the different types of cancer care that exists. So if you go across the board, you can start from the beginning where the preventative aspects of care are addressed, and it takes you into detection of cancer, diagnosis of cancer, the treatment of cancer, and then ultimately end of life, survivorship, and also end of life. These are all different aspects of the cancer care spectrum, and in all of these different areas, there are barriers. We've already started talking about some of those. There is no way that I can cover all of this. And so what I've done is simplified it just a little bit to highlight some of the barriers that we found. So, you know, when we think about how effective cancer care is, it really, the goal or the way that we can measure cancer care is through looking at the patient and looking at the population. And that's pretty much what an epidemiologist does. That's why we do research at a population-based level, to be able to ask some of the questions to see what are some of the issues surrounding care related to cancer and also risk, and how do we address them? How do we develop these evidence-based interventions that will then help us to address the concerns? And so this is why research is so important. But when we think about how do we address the concern, you really have to look at things at different levels. You can look at issues within the individual, and that has to do with biological factors related to cancer. And the spectrum continues to simple things like knowledge. How much information do you actually have to make the decision with respect to, you know, making sure that you are addressing the preventative concerns related to cancer? Or how knowledgeable are you in terms of having a discussion with your physician if the situation should arise where you would develop cancer? What are some of the things that you need to know about? What are the questions that you need to ask your physician? So there are issues surrounding knowledge. There are issues surrounding the knowledge and communication skills with respect to the provider that addresses, affects cancer care. And there are also issues in the local community as it has to do with access to care. How far away are the treatment facilities to you? How are you able to get to where you need to go to get your treatment? All of those issues are part of what we do. We assess and evaluate when it comes to cancer care. So this is my version of a simplified cancer care continuum, where I'm going to just focus on prevention, treatment, and survivorship. Under prevention, I'll talk about cancer screening and preventative care and all of the different aspects of that spectrum that has to do with knowledge and perception, access to information, access and utilization of services. And then when it comes to treatment, decision making is really key. How are you going to make the right decision, and who's making that decision? Is it you and the physician, or is it just the physician alone? Are you involved? Do you have a good relationship with your physician to be involved and informed about what is actually going on with you? How are you making decisions in terms of the approach, and what options are you given? Are you being given options? Access and timing. In terms of survivorship, of course, follow-up care is very key, and I'm actually going to show probably one of the last slides why follow-up care is so important after you've been diagnosed with cancer, because there is always, for some cancers, a risk for developing second cancers and recurrences, and there are things that can be done to help to reduce your risk. So knowledge really is part of prevention. Knowing what you know